Hello, and welcome to another episode of the Thoracic Surgery Residents Association podcast. Today's episode sponsored by Humasonics. I'm here with Dr. Kyle Militich. I'm Nathaniel Reed. Dr. Militich completed his medical school at Wayne State University and his residency in cardiothoracic surgery at the Cleveland Clinic. He is now here at Henry Ford Health System in Detroit, Michigan, and he is the co-director of the Multidisciplinary Aortic Center, as well as the Associate Program Director for the Cardiothoracic Fellowship. Thank you for your time being here today.
Thanks for having me.
And so on today's episode of the TSRA podcast, we will be discussing cardiac tamponade. And so cardiac tamponade, obviously very scary scenario for cardiac surgeons and in particular. And it can be a rapidly fatal emergency that results from an increase in intrapericardial pressure, and that then impairs diastolic filling of the heart and ultimately diminishes your cardiac output. So some of the clinical signs that you can see associated with tamponade are going to be things like chest pain, shortness of breath, tachycardia. You may see some other signs such as oliguria, increasing pressor requirements, things of that nature. And then you also get the classic Beck's triad of hypotension, as well as distant heart sounds and jugular venous distension. Other signs that you may encounter in the ICU setting after a surgery would be an equilibration of your CVP, as well as your PA pressures or pulmonary capillary wedge pressures on your swan, as well as pulsus paradoxus greater than 10 millimeters mercury, or a loss of the Y descent on your venous tracing may also be an indication, because you lose that passive flow from your atrium into your ventricle during early diastole. And you may also get some adjuncts that help to support your diagnosis, EKG showing something like electrical alternans, or low voltages, as well as echocardiography, which will demonstrate, you hope, an effusion, as well as some collapse of your RA or RV, or indentation or wall compression of that RV in particular during diastole. And then you may also see a loss of IVC collapse during inspiration. So Dr. Militich, obviously very scary scenario, but a serious one that I'm sure you have had to manage in the past. And so what are some signs that kind of give you an intuition that a patient may be heading towards tamponade and may need to go back to the OR for exploration?
Sure. Certainly, as you had a nice summary of tamponade and many of the clinical kind of findings that we all learned about in the textbooks. Unfortunately, typically Beck's triad or some of your loss of a Y descent, it's not that obvious when it's you're the resident on at 2 o'clock in the morning and you're trying to figure out why your patient is not doing well. There's really several things though that should raise concerns for tamponade in the early postoperative period. And the first one is increasing hemodynamic instability coming out of the operating room. Now, most patients, especially with good anesthetic management, as well as appropriate resuscitation in the intensive care unit, typically have relatively stable, if not pressor requirements. You can certainly get some vasodilation, but increase in inotropes is one thing that should really concern you about the need for re-exploration. Sudden onset of oliguria is also a very common early sign of tamponade. So patients with new inotrope requirements as well as oliguria should really be initially raising some of your concerns for tamponade. The second thing is looking at your fluid responsiveness. Now, if this is just pump failure, so you have a patient who already had a marginal EF and they had a long operation with multiple bypasses, and you're not sure if it's tamponade versus just worsening pump failure, which oftentimes can happen about 6 to 8 hours after the surgery, which is really the time of peak myocardial edema. A gentle fluid challenge, or even something as simple as a passive leg raising test, if that substantially improves their blood pressure, that's much more concerning of tamponade versus minimal response to fluid should maybe have you think a little bit more in terms of pump failure or vasoplegia.
Absolutely. I think sometimes, I know I forget these bedside tests that you can do, like the leg raise. Absolutely a fantastic bedside tool that we can utilize in order to evaluate our patients, especially when it's 2 a.m. and your patient's not doing well and you're the resident. And so oftentimes patients kind of seem to fall into a gray zone, though, where, it's cardiac surgery. You're going to have patients who are hemodynamically unstable, and you could attribute that to a variety of factors. And maybe one that you're concerned about is, you have increasing pressure requirements and you get a bedside echo to evaluate for signs of tamponade. But the views on your echo aren't great. And I think this is probably pretty common. What are some of the important things, you mentioned a few already, that would trigger you to head back to the OR right away in those patients?
So I'll start off by addressing the echo issue because it's a little bit of a delicate point. I think it's very important for all residents to understand that tamponade is ultimately clinical and not an echocardiographic diagnosis. And even with an experienced echo tech and an experienced cardiologist, if they don't see a effusion but the patient is clinically in tamponade, that patient should go back to the operating room. And you are better off having a negative chest exploration than you are delaying an exploration until the patient is coding or near coding. I think it's, most staff, myself included, will not fault a resident for advocating to go back to the operating room when they're concerned about a patient's clinical course, but they certainly would fault you for delaying intervention because an echo was read by somebody as negative. Particularly at 2 o'clock in the morning, you're probably getting a first-year cardiology fellow reading that echo who's not going to be an expert reader. In terms of what you're looking for clinically, I think the most important thing to think about is that tamponade is ultimately a mechanical problem. And when you have a mechanical problem, pharmacologic interventions will not ultimately fix a mechanical problem. And so if you see a patient who has oliguria and you give volume and that does not improve their oliguria, or they have a low cardiac output and increasing doses of inotropes do not improve that, that should be a really key thing to think about, that this is probably a more mechanical problem of tamponade that needs to be evacuated rather than something like a physiologic problem like low cardiac output state that's just from a poor ventricle. You may get a transient response, but long-term that patient will continue to decline despite any sort of resuscitative efforts in the ICU until that mechanical problem is fixed. And so looking at, even in the relatively short course of 15 to 20 minutes, you improve, you give a fluid bolus, they have a short improvement in their urine output, and then it falls right back down to where it was. You should be starting to think that this may be tamponade. Or you go up on the inotropes and there's no improvement in the cardiac index. Again, that should be setting off alarm bells that this may be a mechanical problem that you're dealing with rather than a physiologic problem with the myocardium.
Absolutely. And in terms of tamponade occurring in the ICU, do you ever see tamponade being associated with a rapid correction of coagulopathy in the postoperative period?
It certainly can happen, and this is another thing to be at least aware of, is if you have a patient who's kind of on the border for exploration for bleeding, something like 150 to 200 cc's per hour of chest tube output, and then all of a sudden that output goes to zero, and they start to get unstable. There is a concern that those chest tubes are clotted, and now that whatever bleeding source is staying within the pericardium and is not able to drain and is causing tamponade. It's certainly not a reason to stop correcting your coagulopathy in a patient that is actively bleeding. But it is something also to think about in a patient with relatively low chest tube outputs who has at least laboratory evidence of coagulopathy, if not clinical, about being judicious in terms of correcting that if it's not absolutely needed. But certainly from a clinical standpoint, patients who have substantial bleeding from their chest tubes that suddenly stop and then they begin to get unstable, that is tamponade until proven otherwise.
Definitely, absolutely. And in your institution, I know you guys utilize kind of a variety of ways to try to reduce the number of re-explorations that are needed. Could you describe some of your practices that you utilize in your practice and in the institution to reduce the number of re-explorations or bleeding that can occur in the post-operative period?
So, really one of the most important things in the operating room, because hemostasis, of course, begins and ends in the operating room, is multiple rounds of packing like everybody does. We do, when we have patients that we are concerned about their degree of coagulopathy, we do a thromboelastogram guided transfusion of coagulation factors. So I think a shotgun approach where you see a patient who looks quote unquote oozy and then you give them a couple units of FFP, that may not be the best or most rational approach to this. It may be a platelet deficiency, it may be a cryoprecipitate, they may need cryo or something like that. So really using TEG to guide your correction of coagulopathy in the operating room before you even leave, I think, is a very important cornerstone of that. We also hear that's sort of somewhat institution specific, but it's worked quite well for us, is we do a kind of a very simple chest tube output test before leaving the operating room. So once the fascia is closed and the chest is completely isolated, we hook our chest tubes up to negative 20 of suction in the operating room before we even leave, and we monitor the output. And what we found is that if they can go with 3 minutes on suction without any bleeding coming out of the chest tubes, it's very rare that they will have to go back for bleeding. And that really is a good way to tell if there's any unrecognized sternal wire bleeders, because those will show up quite quickly, and that's usually sternal wire and chest wall is probably the most common source of post-operative bleeding. And so this is kind of a quick and easy 3-minute way to make sure that you don't have any rapid output. Now, it's not perfect. We still have patients who come back to the operating room for bleeding, but that test is one that we've started to use that works quite well.
Absolutely. And I think any intervention that you can utilize that will reduce the number of re-explorations that are required for your patients is worth doing. So
yeah, re-explorations are certainly unequivocally bad, but the best way to reduce that is to do an excellent operation with minimal bleeding. And as I always tell a lot of the residents, the most common factor deficiency and that's associated with take back for bleeding is a proline deficiency.
And I think that's a great place to leave off in terms of our discussion of this cardiac tamponade today for today's podcast. I think everybody may have a little bit more proline coming their way in the future after listening to this. So thank you very much to Dr. Miletich for his time and expertise, lending it to us for the TSRA podcast. We really appreciate you. Thank you very much.
Absolutely. Thank you for having me.